This is a review of Chapter 1 for HIMT1100 Healthcare Delivery Systems. This chapter begins by talking about the history of medicine. It includes the many different types of medicine that are out there. Now, with prehistoric medicine and ancient medicine, the focus was on unnatural, supernatural items causing illness. There was no connection with prehistoric and ancient to science or art. So this was where they believed that if you did something wrong, then you would become sick. It wasn't until Hippocrates that medicine was considered a science and it was connected to the science. Medieval, this is where they started building the hospitals to help take care of the knights. And then the Renaissance medicine was when they began caring for patients based on education rather than religious incentives. Modern medicine, this is where we started looking at sanitation, ventilation, hygiene, nutrition, and people that were in healthcare, such as nurses and hospital workers, were seen more as educated, trained people, and it became more of an acceptable career. Our early hospitals, the first one was in 1751 in a Pennsylvania hospital, and Ben Franklin actually started it. The early quality of care initiatives, these started looking at performance and care as far as meeting standards. Federal initiatives came about, and these federal initiatives were set so that people were receiving incentives if they met certain standards. Now, in your book, it talks about pages 8 through 14. There's many tables in there where it talks about some of the legislation and the evolution. You need to read through there, and some of the important factors you need to know about include the American Hospital Association, that they came about in 1898. The American College of Surgeons, the ACS, they came about in 1913, and we're looking at quality of care, and they established standards for surgery. The Hill-Burton Act, this was where money was provided for renovations of facilities. We also had Medicare and Medicaid that were part of the Social Security amendments. In 1972, those same Social Security amendments strengthened utilization review, and they formed the PSROs, that's the Professional Standards Review Organizations, and they did peer review and made sure that outcomes were being met. We have the EMTALA over in 1985. That was the anti-dumping. It kept facilities from not treating patients based on whether or not they had insurance. They weren't being screened. 1986, we had the National Practitioner Database, NPDB, and this is where you can see about the practitioner's credentials, malpractice, any adverse actions that's been taken against those physicians. HIPAA in 1996. You had CMS in 2001, that's the Centers for Medicaid and Medicare. In 2005, we had the Deficit Reduction Act of 2005, which created the Medicaid Integrity Program, or MIPS. This was to fight fraud and abuse of the programs. Over 2009, we had the American Recovery and Reinvestment Act. This was where they gave grants if people would work toward having that technology system in place. So those are the tables. Again, that's pages 8 through 14. Review those for your test. Now, under continuum of care, we have four different types: primary, secondary, tertiary, and quaternary. Primary is preventative and acute care. This is your first point of contact where you're going to go for your basic conditions. This is usually family practice. You get your physicals, your immunizations, and the primary care physician may send you off to a specialist. That specialist is known as secondary care. These usually see patients by referral. Tertiary care, these are specialized hospitals or facilities that have special equipment that other areas may not have. Then we have the quaternary. which is where you have multiple levels in one place. These are quite costly, but are on the rise where people are buying larger buildings, and then they're scattering multiple disciplines of healthcare throughout that facility. Now, the next part of the book talks about the healthcare facility ownership. There are 3 different types of hospitals: government, proprietary, and voluntary. Government is a not-for-profit, makes up 25% of all hospitals. Proprietary is for-profit. That would be our private hospitals. They make up about 15%. And then voluntary not-for-profit, these are the largest percentage. They're 60%, and they are either religious or voluntary groups, such as the Shriners that make these. Now, as far as in the facility, this is a listing of the structure. It starts off with a governing body. These people usually serve without pay. They're usually the board of directors, and they can be from multiple disciplines, not necessarily just medical. Administration, they are between the board and the medical staff. The medical staff would be the physicians, providers who have clinical privileges. These are the ones that deliver the care to the patient. Hospital department, services, and committees. This would be the multiple areas that fall under the medical staff. And then as far as successful meetings, all of the committees should have meetings regularly and be organized with agendas, and somebody take in minutes to make sure that they are meeting the requirements. Now, page 19 and 20 in your book, it talks about medical specialties. So you may want to look at those, because what we have to do is we have to be able to recognize those secondary care areas that may be referred to, and know that whenever we're billing and coding, that those are areas that we need to look for other information from. We need to look for referrals. On page 22, it talks about the different hospital committees. Usually these committees are, their name tells what they do. So for example, disaster control, they work on disaster plans. The drug utilization review, they help to determine the formulary, which is the list of meds for that facility. We have the risk management, which analyzes trends and establish priorities. They ensure patient safety. Tissue review, they look at pre- and post-op pathological diagnoses. Then starting on page 23 and going over to page 27 are multiple hospital departments. So these departments, they would talk about what areas that are included in the hospital and what their job is. You can see starting there with the admissions, of course that's patient registration. They register patients, and you'll see there in there it also talks about, they ask about orders, living wills. They may have DNRs that they have information and paperwork, and DNRs do not resuscitate. Case management, these look at what the patient needs when they're discharged. Compliance, of course, they make sure that the hospital is in compliance and not going to be fined or closed down for any problems based on their accreditations. Now, next is a listing of areas that you can work with health information background and information that relates to it. We have cancer registry. These people are credentialed, they take certification, and they do follow-up on all cancer patients, then gather information which is then used for research to help with cancer treatment. Coding and abstracting. Coding is where we assign either a number or an alphabet to a diagnosis and procedure. And then the abstracting is where we're actually taking that information and we're putting it into other areas to gather insurance data. We can do it for research. It's a way of looking at reports and making decisions as far as care and funding for the hospital. Image processing, this is where they're getting ready to go into that EHR, so they may work to convert papers to electronics. Incomplete record processing, these people work to assemble all the discharge records, make sure that nothing is missing, and they contact physicians or employees that may have information that's missing that needs to be in there. Medical transcription, this is where they type up the dictated reports and they put them into the electronic health record. Record circulation, this is where they keep up with the records, where they're located. And then release of information, this is the area where they're looking at whether or not copies can be made or information can be given out to patients about their record. Now, the Code of Federal Regulations, which is known as the CFR, let me say one thing first, sorry. Health Information Department, there's another table that starts on page 33 that again goes through some of those areas where you can work with health information. Now, as far as licensure, regulations and accreditation, licensure is allowing a facility to operate and practice medicine, and each state is the one that's going to give that license. The Code of Federal Regulations, which is the CFR, they are responsible for coming up with the rules that are required and must be met in order to work as a facility and maintain your license. The Federal Register is a newspaper. It comes out daily, and it tells all of the new and current legislation. Accreditation standards and surveys, these are voluntary areas that hospitals or healthcare facilities can be part of to show that they demonstrate standards set by different organizations. Now, next are some accredited organizations, and again in your book, page 35 and 36 go through many of these accrediting agencies. For the most part, their name will help you determine what they're accrediting. So on this page, you see we have Accreditation Association for Ambulatory Healthcare. That's the AAHC. Of course, that'd be ambulatory care. Osteopathic is AOA. CARF is the Commission on Accreditation of Rehab, and then the Community Health Accreditation is the CHAP. A few more. We have the Joint Commission, which used to be known as JACO, or Joint Commission on Accreditation of Healthcare Organizations. We also have the National Committee for Quality Assurance, which is the NCQA. And then lastly, we have the National Commission on Correctional Healthcare, which would be our correctional or prison medical services. Now, a little bit more about Joint Commission. Always remember Joint Commission that they are voluntary. They do have deemed status, which means that if you meet Joint Commission standards, you also meet CMS standards, so it could prevent being audited or surveyed by both agencies. They have the ORIX initiative, which is where they're looking at performance from the beginning to the end. So when they come out and do surveys, they actually will start with a patient and they'll track that all the way through the facility to make sure standards are met. As far as shared vision and the new pathways, the scoring is looking at whether or not the organization is making improvements. The periodic performance review, this helps them comply with standards, and you can also use this as a self-evaluation, again, to make sure that changes are being met. And then the National Patient Safety Goals, this is voluntary reporting of incidents that will help to meet safety requirements, and they usually compare hospitals to other hospitals that are similar in size and in patients that they treat. Now here is some recent legislation. Don't get focused too much on the years, just kind of know the information. The Deficit Reduction Act, that was the one that created the Fraud and Abuse Detection. Patient Safety and Quality Improvement Act of 2005. This is where we had to report health care issues and make changes to improve safety of patients. The Tax Relief and Healthcare Act of 2006. This was an incentive if people were voluntarily reporting incidents. The Genetic Information Non-Discrimination Act, it prevents denying insurance or increased premiums to people with genetic conditions. American Recovery and Reinvestment Act, this was the one that they gave money if you would begin to set up for your information system. HITECH, this was where they placed incentives for meeting certain steps in the process of going electronic. And then the Patient Protection and Affordable Care Act was our health care reform. Few key terms here: continuum of care, that's the range of service. Remember, that was primary to the quaternary. Licensure, this allows you to operate a practice. It's by each state. Regulations interpreting the law, and it can be a state or a federal regulation. Accreditation is a voluntary to show that you meet standards. Standards are steps that look at your performance. Board of directors, these are the governing body. And then they can also sometimes be members that are directors. Governing body, these are those people that are at the top level of the organizational chart, and they usually are not paid. They may not even have health care experience. For your Module 1 exam, there are 13 true and false and 17 multiple choice for a total of 30 questions. Good luck on your exam.